I'm going to talk primarily about how to handle devices in the OR realm, and then a little bit about anesthesia and the EP lab itself. Preoperative assessment starts in patients with a pacemaker or defibrillator by looking at their chest X-ray, EKG, or a scar on the patient itself and taking a history. The biggest thing is to figure out what device does the patient have. Is it a pacemaker or is it a defibrillator? And secondly, is this patient dependent on the device or not? You should look at the last interrogation note in the chart, whether in EPIC or in CPRS, and see if the battery is adequate, and if it's less than 3 months left or if the battery is nearing replacement, then for elective procedures it's recommended that the battery be replaced before the patient is taken to the OR. But if it's good for 3 months or more, then there's no need to worry about the battery. So the key thing is to determine whether the patient is pacemaker dependent or not, and determine whether it's a pacemaker or a defibrillator. Those are the two things important to figure out prior to taking the patient to the OR. A chest X-ray can be a good tool there. Pacemakers will generally have wires that go to the heart. If you don't see any defibrillation coils on these wires, then it's safe to assume it's a pacemaker. Defibrillators, on the other hand, will have these bright white coils. An RV coil will always be there for a defibrillator. An SVC coil may or may not be there. But if you don't see any defibrillation coils, it's a pacemaker. If you see this, it's a defibrillator. The size of the can is also a clue. The defibrillators, of course, are going to be bigger. BIVs would have a third lead, but again, this is a defibrillator because it has a shocking coil. A 12-lead EKG, that will also give you a clue whether the patient is pacemaker dependent or not. If you see pacemaker spikes or a rhythm strip, you should know their potassium levels, and then what kind of surgery is planned and the anticipated amount of EMI from that procedure. Where is the surgery? Where is the grounding pad going to be placed? Again, the key thing is whether it's a pacemaker or a defibrillator and whether the patient is pacemaker dependent or not. Rate adaptive features may need to be turned off in some situations, and I'll come to that. When you look at the pacemaker clinic note, you'll see the mode that's mentioned, whether it is AICDs or DDDR. What does that code mean? The first letter stands for the chamber that is paced, because that's what pacemakers do, they pace. So the very first letter is telling you what the pacemaker is going to be pacing, whether the atrium or the ventricle or both. So if it's D, that means it is capable of pacing both in the A and the V. The second is the chamber that it's sensing. So is it seeing things in the atrium, in the ventricle, or in both chambers? The third is the response to the sensing. So a DDD pacemaker paces in both chambers, senses in both chambers, and is able to inhibit or trigger based on the response to the sensing. A DDI is only capable of inhibiting in response to what it sees. A DOO is going to straight pace and ignore any kind of sensing. So this is usually what magnets will do, and this is usually sometimes that's necessary in pacemaker dependent patients where you want the pacemaker to be blinded to all the EMI, to all the cautery. You put them in a DOO mode, it's going to be pacing regardless of what it is seeing. It is not going to see anything, and hence it has no response to the sensing. R is added for rate modulation. Generally, it's a motion sensor. It's useful for everyday life, but in surgery it may not be. And it's usually just something that you have to be aware of. If you see the chest shaking and that resulting into sinus or tachycardia that is device mediated, so that you are aware that this is device driven due to rate modulation and not because the patient's heart rate went from 60 to 110. Again, first is the chamber paced, second is the chamber sensed, third is the response to sensing, and fourth is rate modulation. Now I'll just go over what each pacemaker modes look like in practice on the rhythm strip. So single chamber mode can be a VOO, which is simply pacing in the ventricle and no sensing whatsoever, or it could be sensing, pacing in the ventricle, sensing in the ventricle, and inhibiting in response to the sensing. If it sees intrinsic activity, it will inhibit. AOO is the same thing in the atrium. So a VOO pacemaker is going to pace regardless of whether it is needed or not. So this is the downside of a VOO mode, is that it could pace in the critical component of the T wave, which is what you don't want, but if it's unable to see, it cannot time, and it will only pace. So a single chamber mode VOO, yes, it's useful, but it can also be a little bit risky in this situation. VVI, on the other hand, will not pace if there is an intrinsic beat present. So since it saw the intrinsic QRS, or if it sees a PVC, either way, it can't differentiate. If it sees intrinsic activity, it will inhibit. That is what that I means. And it's going to be seeing that in order to inhibit. AO is the same thing in the atrium. Here it's pacing continuously regardless of whether P waves are present or not. And AAI is atrial pacing, but inhibiting and not pacing when it's seeing an intrinsic P wave. Dual chamber modes are essentially a tracking as well as a non-tracking mode. You need wires in both chambers of the heart in order to have a dual chamber function. It does everything like a single chamber does, but it tries to maintain AV synchrony. So it'll be pacing in A and pacing in V. This can function in 4 different ways because of the 2 wires. It could either be pacing here and sensing here, or it could be sensing here and pacing here, or it could be sensing altogether or pacing altogether. So this example shows DDD pacing, which is pacing in the atrium and pacing in the ventricle. Here it is simply seeing in the atrium and pacing in the ventricle. Now this can create some confusion. If the lower rate of the pacemaker is set to 60 DDD, how is the heart rate, how is the patient pacing at 80? It's because if the patient's sinus rate is 80, the pacemaker will simply track the sinus activity. The lower rate comes into play only if it is atrially also driven by the pacemaker. But if the patient's sinus rate goes up and it's supposed to be tracking the P wave, it will increase the sinus rate up to the upper tracking rate, which is usually 120, 130. So if you see a DDD 60 to 120 noted in the chart, if intrinsic activity may let the pacemaker track the sinus rates up to 120, 130 as mentioned. Here it is pacing only in the atrium, and because it is a DDD, it is able to sense in both atrium and ventricle. It senses intrinsic conduction and hence does not pace in the ventricle. So this is still a dual chamber pacemaker, but only pacing in the atrium. And here it is not pacing at all because it is able to see DDD. The second D is the seeing part. It is able to see both the P wave and the QRS and then hold off. And the third D is inhibition and trigger. It is able to inhibit because it sees intrinsic activity. So this patient is not pacing but still has a DDD pacemaker because the intrinsic heart rate is higher than the lower rate of the pacemaker. If the lower rate was 80, you would see pacing spikes. If the lower rate is 60 and this patient is going at 65 or 70, it will not be pacing. So this one slide essentially has all the QRS complexes that you can see with a patient with DDD pacer. Here, no pacing seen because of intrinsic activity, atrial pacing seen, pacing in both A and V, and pacing with an intrinsic A and a tracking in the ventricle. Rate response pacing is the ones where you see R at the end of the pacemaker mode. These are usually sensors. Generally, these sensors have accelerometers, which are the motion sensors. Boston Scientific devices have a minute ventilation sensor, so they can actually sense the lung expansion, and based on that can increase the heart rate. There are certain sensors, especially with Biotronic, that look at the heart contractility between the two electrodes, and that ventricular contraction increases if you have higher sympathetic tone, and that will increase the heart rate in response to that. St. Jude used to have QT sensors, but that's gone out of favor. So most of these will be accelerometer, but some of them will be related to breathing. And essentially the goal is to try to be as physiologic as possible with your heart rate. However, during surgery, that might create a little bit of confusion with the accelerometer or the motion sensor kicking in areas that involve chest to be shaken or moved. You could either program the device to DDD in place of the DDDR, or if you're just aware of it, that's all. I mean, you can see a patient with undergoing a sternotomy. Here is at baseline, and here is during the sternotomy. Because the chest is shaking, the heart rate goes up in a DDDR mode. Noise. Any electromagnetic activity to a pacemaker or defibrillator can be viewed as intrinsic rhythm, and the response of the device then would be what it is going to do when it sees things. If it sees things other than the heartbeat, it's labeled as noise, but the pacemaker doesn't know this is other than a heartbeat. The usual sources are the electromagnetic interference from various devices in the room, stray electrical signals, and sometimes myopotentials. Succinylcholine can cause some myopotentials. The pacemakers, it will reset its refractory period and essentially inhibit if the mode is set for inhibition. If you have a DDI or a DDD mode, it will then inhibit and not pace. And sometimes if it sees too much noise, it can go into a noise reversion mode where the pacemaker is actually recognizing that it is noise, and it automatically will switch to a noise reversion mode, or what's called a backup mode, so that it does not inhibit the pacemaker and continues to function as a pacemaker. So the pacemakers have somewhat of a safety net built into it for a noise reversion mode. If the pacemaker does go into a noise reversion mode, then at the end of the procedure you have to manually program it back into a normal mode. And the way you'll see that asynchronous pacing is if it starts pacing at a rate of 85 or at a rate of 100 when it was not pacing before, or if it was pacing at a lower rate. If it gets stuck at 85 or 100 beats a minute, pacing all the time, that means the pacemaker itself went into a noise reversion mode. With bipolar cautery, usually the noise is not an issue, but bipolar cautery is less effective, so less used. Monopolar cautery is mostly used. Here the key is that the grounding pad should be placed as close to the cautery site as possible, and as far away from the pacemaker or defibrillator site as possible, so that the current from the cautery to the grounding pad is not going to affect the pacemaker or the defibrillator. Now for surgeries below the umbilicus, where grounding pad can be placed on the thigh, sensing will usually not be an issue. So your question about the inguinal hernia repair, I think it's not going to interfere even in a pacemaker dependent patient as long as the grounding pad is placed below on the thigh area. The only other thing is that sometimes the cautery tip, if it is in contact with the tissue or with another instrument before it is activated, then it's not going to generate an extra source of current. But if the surgeon activates the cautery before touching the patient, then you can have an arc of the current go from the tip of the cautery to another instrument, and that can generate some kind of a noise that the pacemaker a little bit further away may pick up. So, and I've been bad at this as well, to start the cautery, 3 millimeters above the site of incision. And if you're in contact, then start the cautery, you'll have less interference than if the current has to jump in the air. But I think the key is to keep the grounding pad as close to the tip of the electrocautery as feasible, and secondly, the current direction should be away from the pacemaker or defibrillator. In situations where EMI is likely, or if it is above the umbilicus, then it's best to reprogram a defibrillator to a monitor-only mode. Now, defibrillators work as pacemakers and defibrillators. They will continue to pace, but you can turn the defibrillator function off by what's called the monitor-only mode, where it'll record but not act. And this can be fairly easily achieved by putting a magnet on a defibrillator. And I'll come to the magnet part later. For patients who are dependent on the pacemaker, then you have to reprogram it to a DOO mode. So that's why determining whether the patient has a pacemaker or defibrillator, and B, whether the patient is pacemaker dependent or not, are the two critical components in the preoperative assessment of these patients. Now, a magnet will also do this job, but if a magnet is in or near a surgical field, then you have no choice but to actually program it with a programmer. Now, I've run into this once before, where a surgeon's headlight will prevent you from the programmer communicating with a device. And it's happened with Medtronic a couple of times. If your programmer does not talk to the device, maybe turn the surgeon's headlight off. Intraoperative care, emergency pacing systems should still be available with resuscitative equipment. If an ICD is to be disabled, the patient should ideally be on telemetry from the time it is disabled to the time that it is enabled back in the PACU. And magnets can be used if you know the effect of the magnet on the device. Now, what do magnets look like? Here are the common ones, but what do they do? The magnets on pacemakers will essentially completely take away all sensing. They will force the pacemaker to pace. That's what magnets do on pacemakers. They make them pace. Magnets on defibrillators only inhibit the defibrillator function. They do not affect the pacemaker function, which means if you have noise externally in a patient with a defibrillator, the defibrillator will not shock for noise, but it might not pace either, because it does not affect the pacemaker function, and that noise may be viewed as intrinsic activity, and the pacemaker portion will not work. So magnets on defibrillators do not affect the pacemaker function of the defibrillator. Hence, you will need to reprogram these patients who are pacemaker dependent but have defibrillators. It's a little bit of a confusion, but magnets on pacemakers will forcibly pace. Magnets on defibrillators only turn the defibrillator function off, do not affect the pacemaker function. That'll have to be programmed manually to a DOO mode if the patient is pacemaker dependent and has a defibrillator. This is a busy algorithm for preoperative assessment. Again, the key component here is trying to see whether the patient has a pacemaker or a defibrillator. Will EMI be an issue or not? And is the patient pacemaker dependent or not? That's what it boils down to essentially. If you do place a magnet, you can safely take it off at the end of the procedure and it does not require reprogramming. There are a subset of Boston Scientific defibrillators that needed to be manually programmed after a magnet was placed, but most of those have now lived their lives and have been replaced with newer models. Special situations where pacemaker or defibrillators would have to be dealt with slightly differently. If the patient needs a cardioversion and has a pacemaker, an antero-posterior defibrillation patch location is better than an anterolateral. It causes less current affecting the defibrillator because the current in this field is smaller versus the current in this anterolateral projection for a pacemaker. So AP position is preferred in patients who have cardiac implantable devices who need defibrillation. And a minimum distance of 8 centimeters or preferably 10 centimeters is advised from the can for the anterior patch. So if it's here, here, and if it's here, a little bit to the side. So 8 to 10 centimeters in AP preferred over anterolateral. For ECT, myopotential oversensing may be an issue, but generally only with unipolar lead configurations. But I don't expect anybody to know whether the device has a unipolar or a bipolar lead configuration programmed. Most pacemakers will be bipolar, so it's rarely an issue. The other thing, however, is that if you get sinus tachycardia post the seizure, then you need to know what the ICD detection rate is set at. And you might have to give them beta blockers in patients. Let's say if the ICD is set to act at 160 plus, there I would probably consider a preoperative beta blocker. But if the ICD is set for 188, then it's probably not necessary. But it's just something to be aware of, that anticipate sinus tachycardia with ECTs and make sure that the ICD is programmed well above that. For GI procedures, if electrosurgery is planned, like snipping, then you have to treat them like any other patient undergoing surgery above the umbilicus. But if it's going to be a routine check, then you really don't need to worry about it. So it's again the electrical component that can cause the EMI, and these patients should be treated like any other above the umbilicus patients. Tissue expanders are sometimes used in reconstructive breast surgery. If they are used, they come with or without magnets. The guides with magnets should not be used in patients with pacemakers or defibrillators. TENS is not recommended in pacemaker-dependent patients, but it can be used in patients who pace otherwise but are not dependent. Again, lithotripsy, in general, you can do it safely by using continuous telemetry. If you see something, stop at that point. If you see inhibition of the pacemaker function, then you can use a magnet. Overall, the risk is low. Generally, if you are aware that a patient has a pacemaker and you're going to be looking at the telemetry, you're okay. There is no other special need than to have a magnet available at that time. Coming to temporary pacemakers that are placed post-operatively, pacemaker sensitivity is the minimum current that the pacemaker is able to sense. So let's say 1 or 2 millivolts. A lower number thus corresponds to a greater sensitivity. So if it can sense a smaller signal, means it is more sensitive. Even though the number is opposite of what you would think, going from 1 millivolt to 2 millivolt is actually making it less sensitive. If you want the pacemaker to be pacing all the time, just raise the sensitivity to 4 millivolts and it probably won't see anything below and it'll pace all the time. But if you want it to be appropriately seeing, then generally 2 millivolts is where it is set to. If you want to be precise, then you should see what it is sensing. The green light comes on when it is the orange light comes on when it is sensing, green light comes on when it paces. And you can tone down the sensitivity and see where you stop seeing the orange light. That is your sensitivity measurement, and then set it for half of that amount and you will be safe. So sensitivity is programmed at half, threshold is programmed at double. Capture threshold is the minimum pacemaker output required to generate an electrical impulse that captures the myocardium. Again, you lower down the pacemaker threshold until you lose capture, and you should program it then at least to twice that amount. But generally, for temporary pacemakers, I would not go below 10 MA. They go from 10 to 20, or some models up to 25 MA. I don't think anybody should be programmed less than 10 MA if it needs spacing. But generally, check the threshold and have at least twice that amount as reserve. And rate is sometimes available. Rate is always available. Rate response is sometimes available. And the rate has to be set. Generally, post-op is at 80 beats a minute. This is what the pacemakers look like. Atrial and ventricular outputs, 10 MA. I would not go below 10. PR intervals nominally comes at 150. If you want to pace, if you do not want it to pace in the ventricle, you can extend it up to 250. Lower rate limit, if it's a backup pacemaker, generally 40. Post-op, generally set at 80. Atrial sensitivity 1, ventricular sensitivity 3, and that is PVARP is determined. In a dual chamber mode, that is how it usually comes as. So this is what the programming would look like post-cabbage or post-valve most of the time that you'll need. So don't go below 10 MA, have at least twice the threshold covered, and the lower rate. Coming to anesthesia in the EP lab, generally prophylactic antibiotics are administered for device implants, not for ablations. Pacemakers and ICDs are performed under sedation with local anesthetic. A subpectoral placement or a submuscular implant will require deeper sedation because it hurts more. And BIVs and ICD patients usually have a lower EF. That is why they are getting a BIV or an ICD. And during ICD testing, which has now become less, maybe 1 out of 10 patients now that might require deeper sedation transiently. Catheter ablation, it's generally a moderate sedation for most right atrial procedures. General anesthesia is used for most left atrial or ventricular ablations. And the reason for that is we don't want the patient to move and mess up the map. That is the main reason practically. For AFib ablations, we'll have a temperature probe in the esophagus, and heparin is generally used for all left-sided ablations. Again, these are the 3 magnets that are placed underneath the table, and the catheter tip has an X, Y, Z axis and records a point. That's why if the patient moves, the whole map is off. Hence the main reason for requesting a general anesthetic in these patients. It's really the patient motion once you start building the map. If they move before you build the map, it's okay. Then you just have to remap them. The esophageal probes, I'm sure most of you have seen this for AFib ablations. Again, the idea is to back off on the heating or cooling, cryo or regular ablation, if you detect a drop or a rise in temperature in the esophagus for the left atrial posterior wall burns. Again, radiation exposure to anesthesiologist has doubled since EP procedures were introduced. They should know what ALARA is as far as low as reasonably possible. Staying away from the source, decrease in exposure time, wearing lead, thyroid shield and leaded glasses, and rotation. Not the same person all the time. And I don't know if you guys wear personal dosimeters or not up in the EP lab, but I think in hybrid ORs or in EP labs, it should. And that's it.